Scleral contact lenses. Hello everyone, I'm back again with a talk on fitting and assessment of corneo, scleral and scleral lenses. Now the speaker before me had spoken at length about fitting soft spherical lenses, soft toric lenses and rigid gas permeable lenses, the corneal lenses. Now the lenses that I'm going to be talking about is the comes under the specialty lens fitting, right? So these are not regular lenses. If you find a regular refractive value, you don't recommend any specialty lens because these are specially designed for irregular corneal conditions. So before I move on, we all need to be on the same page and get to know about the terminology of gas permeable lenses. So in our country, in majority of the times when we mention RGP lenses, I fit RGP lenses. Please try to understand that RGP is rigid gas permeable material. So you can have a rigid gas permeable material in a corneal lens, in a corneoscleral lens or a scleral lens. So whenever you mention it, you have to mention it with clarity. Like what is a corneal lens is one which has a diameter ranging between 8 to 12.5 mm and has all the bearing on the cornea and there is no tear reservoir. So this is how an RGP lens looks over the eye. If you talk about a corneoscleral lens, it is otherwise known as semiscleral lenses or corneal limbal lenses. The diameter ranges anywhere between 12.5 to 15 mm and it has a shared bearing on the cornea and the sclera with a limited tear reservoir. So this lens kind of looks like a soft lens over the eye, but the material is a rigid gas permeable material. Talking about the next lens, which is the scleral lens, which is gaining popularity in the recent times because of the advancements in materials and design, which are also called haptic lenses. They are again classified based on the diameter of the lenses as mini scleral and large scleral lenses, where all the bearing area is on the sclera, not on the cornea. It completely vaults or bridges over the cornea. And the mini scleral lenses have somewhat limited tear reservoir capacity, whereas the scleral lenses have unlimited tear reservoir capacity, and this is how a scleral lens looks over the eye. Now you notice that under the corneoscleral lens also I mentioned 15 mm dia. It could be a 15 mm corneoscleral lens, and you can have a mini scleral lens which is 15 mm dia. The difference between the two, it is not the size by which you classify, it is based on the design in which you classify. A corneoscleral lens will have a shared bearing between cornea and sclera, whereas a mini scleral lens of 15 mm will have all its bearing on the sclera. So you need to be very clear about the terminologies of gas permeable lenses before I move further in my talk. So basically the corneoscleral lenses roughly are around the soft lens diameter of around 14.6 mm and scleral lenses can range anywhere 15 mm upwards until 24 mm also depending upon the condition. But because of the anatomy of the eye, nasally it is flat and temporally it is steeper, there is a tendency for scleral lenses to show inferotemporal decentration when fitted on the eye. So you need to understand it is basically because of it follows the anatomy of the eye. So talking about the corneoscleral lens or the semiscleral lens design, every lens has a fitting philosophy what you need to adhere to in order to achieve a good fit. So basically when you talk about fitting a semiscleral lens over the eye, you need to have a central clearance at the highest point on the cornea, and the landing zone is inside the limbus with a 20 to 30 micron clearance over the limbus, and it should be parallel to the sclera to ensure that there is tear exchange. Okay, it is never a seal off over the eye, there is tear exchange happening with corneoscleral or semiscleral lenses. So talking about the fitting system, it follows these 5 steps. You need to work on the central fit, that depends upon the base curve that you have chosen. Next you move on to assessing the peripheral fit. Then thirdly the overall diameter, followed by the location and lens movement. So first step is the base curve. So you have to follow the fitting guideline of the manufacturer as to what is the given condition and what will be the first lens or the trial lens. In this case I have chosen the Rose K XL lens, which is a Manicon product. Okay, so I'm not going to go into the details, but this is what is an ideal central fit if it's a case of keratoconus. Is there a pointer? So if you notice, the highest point in a keratoconus case is over here. So you have to achieve a clearance over this area. Whereas in a post-graft case, you see that the highest point is along the periphery of the cornea. So that is the highest point. So whenever I say central fit, central doesn't mean center of the cornea. In an irregular corneal condition, the center is the highest point of the cornea. In the keratoconus, it is the highest point of the cone, whereas in a post-graft case, it will usually be along the periphery of the cornea. So that clarity needs to be understood, because most of us get confused. When I say central, they look at the center of the cornea. So that is not the case in these designs. So the flattest base curve which shows no touch is the base curve that you need to choose for a corneoscleral lens design. This is not based on the sagittal depth but on the base curve. I am talking about corneoscleral lenses. So this is how the lens would fit in a post-LASIK case with ectasia. You see, as the eye blinks, there's a dark area which might be mistaken for an area of touch, but with blink you see enough fluorescein circulating beneath the lens. So this is an ideal fit. Also, you need to have an optimum edge lift, right? So the vessels are not camouflaged or impinging, so they should all run and it should be visible beneath the edge of the lens. So conjunctival vessels should be visible. So if there is insufficient fluorescein along the edge, you need to increase the edge lift. If there is excessive, you need to decrease the lift. And a fluorescein band may be irregular if peripheral astigmatism is present. So before I even say that you go in for a corneoscleral or scleral lens, corneal topography mapping is very, very important. That gives you an idea of the profile of the cornea. That will help you choose the right design, whether it is a prolate or an oblate cornea. Based on that, your choosing of the lens design becomes imperative. So this is an ideal lift where you see enough fluorescein along the edge. There is no impingement or blanching of the conjunctival blood vessels. So judging the peripheral fits, like I said, corneoscleral lenses, there is a shared bearing and there is no edge seal-off happening. There should be ample tear exchange happening by the edge of the lens. So this is a simple test to ensure that there is 360-degree exchange of tears happening by instilling fluorescein and trying to push the fluorescein. If it's easily entering under the edge of the lens, that means adequate tear exchange is happening. If considerable force is being applied to push the fluorescein beneath the lens, then probably it's a tight edge which requires an increased edge lift. So ideal diameter should be 1.3 to 1.5 mm beyond the limbus. Okay, it is somewhere close to your soft contact lens diameter, I would say. So again, you can have the liberty of increasing or decreasing the diameter based on the HBID of the patient. So lens movement, the ideal lens movement is just discernible. You don't have to have great movement with the lens, because otherwise it will not function properly. So you need to judge the movement at the 6 o'clock meridian, especially if you see at the slide on to the right, where the patient is asked to look up and blink. So on first insertion, the movement will be more, but as the lens settles down with time, a 0.5 to 1 mm becomes too much. So the movement should be just discernible. And excessive movement becomes very uncomfortable for the patient, and there could be differences in vision also. So this is a case, the left video that you see is a case of excessive lens movement, and the one to the right is hardly any movement. So both are extreme cases. You want just discernible movement in your corneoscleral case. So this is a very simple case of a 14-year-old male with early keratoconus post C3R. Refraction, the refractive condition is minus 1.75 with a minus 3 axis, 85, 69 partial vision. And mean K values have given over here. So he was advised a contact lens trial. So what I see with the recent, very many designs have entered the market, especially with scleral lenses. So as practitioners, everybody jumps into fitting the scleral lens first. So as a practitioner, you need to be very mindful. Scleral lens should be the last design that you ever choose. You should always start with a corneal rigid gas permeable lens and see if it's working for the patient. If this doesn't work, I move on to my corneoscleral lens design. If that doesn't work, then I move on to the scleral lens. So even for an early case of keratoconus, I see people or practitioners, jumping into fitting a scleral lens, which is not at all required. Every lens has its own pros and cons, and remember, these are compromised corneas. You need to maintain the integrity of the cornea. The corneal health is very, very important as practitioners. It's not about improving vision, it's about improving the quality of vision for our patients that we need to look into. Right? So this is just to tell you that not every case requires a scleral lens. That's the reason why I have given this condition, because keratoconus scleral lenses has become a mantra for most of the contact lens practitioners in the country today. So this is again a case, 37 years old male with post PK. So there are specialty lenses with a post-graft design available. So our first lens, as you see the topographical picture, the periphery is extremely steep and it is quite decentered also. So as a protocol, I usually try a corneal RGP lens design first. So when I tried, the lens fit was not really great. If you see, the vision of this patient was 6/12 partial. I really don't go by vision, to be honest. I need to have the fit of the lens good, not compromising the cornea in any which ways, and then comes the vision. Right? So it did give 6/12 vision, but the lens was rocking over the cornea because of the profile of the cornea post penetrating keratoplasty. The corneal lens was not an ideal lens. Nevertheless, I did give it a try. So the next option was to try a semi-scleral or a corneoscleral lens design. So this gave me a really good fit, and the vision also, you see, there was a drastic improvement in vision from the corneal lens design, and the visual acuity was 6/9 N5. So this was the final lens that we gave for this patient. Moving on to scleral lens, just like every lens has its fitting philosophy, scleral lens also has its own fitting philosophy. So basically, if you see, look at the indications for scleral lenses for ocular surface disorders, irregular corneal conditions, and for high refractive errors which can otherwise not be fit with a regular corneal or a corneoscleral RGP lens, you can give a scleral lens. So the fitting principle is to achieve the scleral zone alignment, because all the bearing is over the sclera. So you have to achieve scleral zone alignment with minimum corneal contact. Okay. So you also need to understand the profile of the cornea. So because these lenses go beyond the limbus, so it is not just the corneal topography, the scleral topography also needs to be understood in all our cases. So when you talk about the design of a scleral lens, it usually has a spherical optic zone, a transitioning aspherical zone, followed by a spherical scleral zone. So there is no method to calculate the scleral zone radius. Basically, when you fit a scleral lens like a corneoscleral lens or a spherical RGP lens, you go by the base curve selection, right? But in a scleral lens, you don't go by a base curve selection, because the lens completely vaults or bridges over the cornea. So you go by the sagittal health, sagittal depth. So every manufacturer will have his own fitting guidelines, but majorly it revolves around the sag height only. So you have to look at the profile of the cornea and decide whether you need to go for a low sag, mid sag, or a high sag value. Okay. So scleral alignment is very important. So you should have optimal apical clearance with aligned scleral curve. The figure 5 and 6 shows excessive apical clearance with a steep scleral curve, and the figure 6 is an optical apical clearance but with flat sclerals. Both are extreme conditions and not advisable to go in for such fits. Also, you need to ensure that there is adequate limbal clearance, because it vaults over the limbal zone as well, and the lens should demonstrate clearance at and extending beyond the lens limbus in order to protect the stem cells and reduce the risk of hypoxic events. Sometimes there is compression at the limbus, so that could also end up with corneal edema, because there are debris collection and then there is reduced oxygen reaching the cornea, so there could be a contributing factor. So you need to look at these aspects. Adequate corneal clearance is definitely required. So these are few examples of central fit where you see, where there is a compression of the apical contact. Okay. So how do you assess the central vault? So there are very, very many fitting scales that are available. You can Google for it and you can compare it. So initially when we used to fit scleral lenses, we used to compare the clearance based on the thickness of the cornea, but that's not recommended. Now every trial lens comes with the central thickness of the lens. I'm actually combining two talks, so maybe get some extension of time. I'll just wind up as soon. So you need to compare the contact lens thickness with the clearance. So that will give you an idea whether you have adequate clearance over the cornea or not. So minimum 200 to 300 micron clearance is recommended. So what are the 5-step fitting approach for scleral lenses? First is the diameter selection. Second is the clearance over the cornea and the limbus. The landing zone fit. Assess the lens edge, and then the surface design or customization. You can ask for toric periphery or a quadrant specific edge lift or an asymmetric corneal technology or a notch on the lens in case of a pingicula or a filtering bleb which is noticed because it is extending way beyond the limbus. So you observe the eye from the side to choose the diagnostic lens with low, medium or high sagittal height. This is more than enough. Sometimes there is too much of scarring over the cornea that a topographic picture availability would be questionable. So in that case, you just have to look at the profile of the cornea and choose your lens from the trial kit. So there could be some potential scleral lens related causes for corneal edema like inadequate limbal clearance or a material related issue or a central thickness issue. So you need to troubleshoot based on what is causing that corneal edema and take the necessary measures. So there could be a case of limbal bearing, so you can increase the scleral lens diameter to increase the limbal clearance, increase the sagittal depth at the limbal zone of the lens, or adjust the optic zone to avoid limbal bearing. And there could be instances because it acts like a suction cup over the eye at the anterior segment. There could be cases of conjunctival prolapse. Okay, so in that case you can reduce the excessive central clearance or limbal clearance and troubleshoot. So midday fogging is a predominant complaint with most of the scleral lens wearers. So generally you advise them to remove the lens and refill with the solution and refit every 3 to 4 hours. Sometimes every 2 hours also in certain cases. So you need to, if you're giving too much of vault over the cornea, that could also be a cause for midday fogging. So you need to assess the fit very well and not give excessive corneal clearance also. So these are very many solutions. Unfortunately, because of constraint of time, I'm unable to go through all of them. So when you're talking about case analysis for fitting scleral lenses, you need to look into the patient history, the topography if it's available, clinical findings of that condition, deliberate why you need to choose a scleral lens for this particular patient and not blindly jump into saying, okay, this is a case of irregular cornea, I have to fit a scleral lens. That's not your approach. You need to look at the profile of the cornea and decide, will a corneal lens help or a corneoscleral lens help or a scleral lens. If in doubt, start from the corneal RGP lens and move or progress towards a scleral lens. And next comes most importantly fitting and assessment and troubleshoot when need be. So these are the various cases for which scleral lenses were fit of keratoconus, moderate to severe cases of keratoconus in which a corneoscleral lens doesn't work, ocular surface dry eye conditions, in that it works beautifully. So the take-home message is not all irregular corneal conditions require scleral lenses. Pre-fit evaluation is crucial before exploring options. Be familiar with availability of lenses and fitting guidelines. Periodic follow-up is very important. Maintaining corneal integrity is important. Reiterate the importance of care and maintenance during every follow-up visit. Fitting specialty contact lenses is a great practice builder, gives personal satisfaction and patient loyalty. So make a difference to these patient lives as well as yours. So thank you very much. These are